Hi, everyone. Thank you for joining the 7th Asia Pacific Glaucoma Society webinar. I'm Kiho Park, the current president of Asia Pacific Glaucoma Society, and I'm very glad to co-moderate this webinar with Dr. Norman Aquino, our Honorary Secretary General of this society. May I have the introduction slide? So I'm very glad to have an opportunity for a few minutes to introduce our Asia Pacific Glaucoma Society members' benefits. The benefits include a registration discount to the Asia Pacific Glaucoma Congress and access to APGS online educational platform with recordings of APGS webinar series and surgical videos. The members may receive quarterly newsletter. The members may access to APGS online communities and also to the Journal of Glaucoma with free. The members may have right to participate in the electoral process and also right to participate in the collaborative activities. Members may have networking opportunities and also eligibility for awards and recognition. May I have the next slide, please? So, as mentioned, you may enjoy our APGS webinar series in our educational section. For example, APGS AGS webinar or APGS EGS joint webinar, and also APGS ISGS joint webinar, and including other webinar series from the first one to the recent one. And also there are a lot of video materials you may enjoy. So I'd like to introduce our co-moderator, Norman Aquino, who will introduce our invited speakers of this webinar. Dr. Aquino, please.
Thank you, Professor Park. Tonight, we will be having another major educational activity of the Asia Pacific Glaucoma Society, where we will be privileged to be hearing from 3 recognized and renowned glaucoma specialists who will take us through very important issues regarding glaucoma management and diagnosis. The first to speak is Professor Manchima Makorwatana from Thailand, who currently serves as the Director of Ophthalmology, the Director of the Clinical Glaucoma Fellowship Training Program, and the Ophthalmic Residency Training Program, and the Director of Academic and International Affairs at the Thammasat University in Thailand. Our next resource person is Professor Leonard Yip from Singapore. He is the Deputy Head of the Department of Ophthalmology and the Head of the Glaucoma Service of the Tan Tock Seng Hospital in Singapore. He is the President-elect of the College of Ophthalmologists and the Vice President of the Glaucoma Association of Singapore. Our final speaker comes from a little far away from the Asia Pacific region, and we will have Professor Marta Pasos from Barcelona, Spain. Currently, she works as a senior glaucoma specialist in the Hospital Clinic of Barcelona and is a clinical associate professor at the University of Barcelona. Professor Pasos likewise serves as a member of the Executive Committee of the European Glaucoma Society. So tonight, I would like everybody to look forward to 3 very important lectures that will guide us through the practice of the specialty of glaucoma. So let us start and begin with the first lecture from Professor Mancina.
Hi, everyone. It is really my pleasure to participating in this program. My talk will be about how everything comes together in glaucoma management. As you all know, that treating glaucoma is not just only a one-time treatment, but it's a lifetime treatment, and you also need long-term document to manage this patient effectively, such as if patients has any change. Is it a real change? Do you need any aggressive treatment, or are you just observing them for a while and then do other things? So those needs lots of documents comes together. So the way that you manage these documents are really matters to what are you gonna do to your patient. This is my financial disclosure. If you're talking about innovation, definitely it make life easier. Somebody gonna tell me, I don't need the innovation. I can live with it, but you know what? Here it comes. And whatever you want it or not, it is there. Before that, we have to use cash. Right now, we use just only credit card. We have lots of, maps and things and documents, but right now we use just only one phone. You can go everywhere around the world. And if you can imagine, in your pocket, if you leave your home for just 10-15 minutes and you just realize that you forgot something. If you forgot your purse, or if you forgot your phone, which one that you have to go back to your home to take it? I would say 10 years back, if you forget your purse, you have to get back to them. But right now, without the purse, but if you have your phone, everything is possible, right? So you can cash them out from your phone. You can pay things from your phone. You can do any information from your phone. But without your phone, you have to get back to take it. Yeah, right? So that's why we need the innovation. That's why we need the technology, because technology make life a lot easier. Same thing with glaucoma problem, because as you know, glaucoma document, there are loads of things in there. There are fundus photograph, which is different in each time and in each eyes, and also the visual field, which is a different protocol and also different time. The OCT, the trend of intraocular pressure. So those are needed and have to integrate it all together to manipulate patient effectively. This is the video that shows, earlier when we have the paperwork, especially in patients who have glaucoma and follow up with you for 7 years, 10 years, you have loads of things in your file. And it's going to be a thick file with lots of things that you have to flip on and off, back and forth to see, is there any change? Is there any problem with this eye or not? Is this a reliable test? You have to go, flip back and forth, definitely, to make sure, right? But with the new things, the EMR, electronic medical records, definitely you get it better, but it's still, you need to go this one, that one, to see the patient and integrate all of them together by yourself. With the clinical records, it's probably in just only 1 pages, but fundus photograph, you probably have to go to another computer. The OCT, you probably have to open another file. Which is, it's all over the place, and you have to just, click on and on and on, and then compare them and remember them. That's the most things, which you probably can't remember. You can see that the visual field is like the long list there. How could you integrate them with the memory of yours, right? So it's not that easy. So when it turns to the forum, the glaucoma workplace, it make life a lot easier because it's all in one. You can see definitely the clinical records by 1 page, the same, but you can see the fundus photograph, you can see the OCT, you can see the visual field, and also integrated them all together. And you can tell that this is the real change. This is what you need to treat aggressively at this point, or patient need to have something. Yeah, let's see. This is my patient, right? We click them in. We can see that the 4 part in the right is the one that she has any response. And also we can integrate them. We can compare them. We can compare the OCT with the visual field. We can compare the fundus photograph with the visual field and also the RNFL. We can integrate them all together and make them all effective, which is a lot save of time and also very effective. And yeah, as you may notice, one phone you probably just use for like calling, paying, or do the stocks, but it actually can give you lots of benefits which you don't know. Same thing as the forum, or same thing as a new technology that sometimes if you don't play with it, and if you have no time to play with them, you probably doesn't realize that you have lots of information in your hands. This forum is the one that combine everything, integrate everything all together, and not just only from the Zeiss company, it's from others company as well, but you have to unlock the code to make them join the data to each other, and then you can integrate them. And also the most sexiest is you can interact with the data as well. Like you can cut some data out, you can zoom in which data that you need, things like that. Yeah, like the Forum Glaucoma Workplace can give you the data clinically relevant. Like if you see the visual field that is changed, the long-term visual field index can tell you is this visual field is strongly documented that it is stable, or it seems like the trending is going downhill and you probably need to treat this patient more aggressive. Yeah, because it changed in the baseline. And if you don't know or doesn't confident enough, you probably compare them with the OCT scanning of RNFL thickness and also the RNFL graft, and also compare them with the normative database that the machine provides for you. And definitely the normative database is just give you some baseline and some clues that this patient has something changed, and also the training of each patient themselves to see is there any change between previous and right now. So you can tell the change of those. Is it a really change, or is it just only the visual field defect that come from patient that is not concentrated on that day, or it's just a real change because you see the RNFL defect at that point, and also you can see the trend down of that RNFL for a while. So it confirms each other. So you can have more confidence to start treatment this patient. And also the interactive of this data, you can deselect some data that you believe that this one is probably not a good one. So you just cut them out to make the statistic more reliable. So these are really helpful in terms of me, and also because we are seeing patients a lot in one day or in one session, you have loads of data that you have to concern. And if the machine can detect them and also remind or remarks that this one is probably something significant that you have to look on or look for, that is really important. Like this sign is the one that display and to remark you that there's something wrong with this patient. There is asymmetrical between the right eye and the left eye. So you see and you look on them. They just remark to help that you do not miss something there. And also the color code is also help you, because with a quick look, for the quick one that you probably see that, oh, this patient probably has nothing, and the test seems like it's stable. So if there is any remarks comes up, it's probably remind you that, oh, you have to take a second look or deeper look or dig the details about this patient so you won't miss anything that is important, which is really matter, right? Because definitely if you have loads of documents and you can analyze them and you believe that the analyze that you have can make the patient like stable in their glaucoma, you probably see the patient in next like 6 to 8 months. But if you have not enough data, you probably have to see the patient more frequent, which is not good for you and also the patient, right? So those will help. And also this one is the Glaucoma Workplace, which is it can support it can be supported by the HFA3 Theta Faster, which is the new, which is going to turn out to be a standard one for the visual field test because it's faster and it can detect the same thing as previous protocol. So the SERAS ganglion cell analysis progression integrated with the Theta Faster, and also it can tell the trend of the RNFL and the glaucoma that is stable or seriously a problem, or the new things that happen, and that's going to make us have a right decision to this patient. So my take-home message is that early detection is a key in glaucoma management, and definitely you cannot do the earlier detected if you have no strong document enough. So the document is really the key. The document that you have is not just only, check the IOP and then you said this patient is okay. Not just only you look at the photograph today and you said this is okay. Even though the photograph or the fundus photo or the OCT is green, the fundus photograph, it seems normal. But if you compare them in the previous and you see some change that is significant for some things as well. And if you can detect that earlier, that's the better for the patient, right? Because you can keep this eye to have the vision and protect the loss as long as you should. And follow-up effectively depends on many factors. Reliable documents is really important. And also, if you can see them fast with less time, more efficient, there is something to remind or remarks you that there is something wrong over here, and you analyze them and you feel that, okay, this is a real one, this is not the one that I concerned, so next time I'll redo that again. So that's going to help you, not just only you by yourself, but the machine will help and support you to confirm that this patient is okay or not. So the innovation and technology will fill up the physician's management gap and human error, but definitely it will not replace whatever you are taking care of your patient. The careness that you have, the concerns that you have, the machine could not replace them. But it can help you to detect something underneath or something that, under your nose that sometimes you just miss them by, screening them too fast and less time. So it's going to save your time, make your patients has been treated effectively, and also your care will be beyond the standard that we need. And we can save the vision and quality of life of that patient longer as we wish. Thank you so much.
Good evening. I'm Dr. Leonard Yip from Tan Tock Seng Hospital, Singapore. These are my disclosures. In order to reduce duplication with the earlier talk, I will be concentrating more on the macular cube scan and the PanoMap function. The SERAS OCT will already be very familiar to many of you in the audience, being in service for many years. Its service in assisting glaucoma management, however, continues to evolve over time with new features added over the years. In glaucoma management, arguably the most commonly used feature is the optic disc scan. The optic disc scan data, once analyzed, gives us useful optic nerve head parameters and retinal nerve fiber layer measurements. And as you have heard in the earlier talk, can be used in conjunction with Forum Glaucoma Workplace. Displays such as seen here make follow-up methodical. It is easy to appreciate the glaucoma in this eye is stable. In contrast, the other eye looks to be progressing, with the overall retinal nerve fiber layer thickness likely to be decreasing, and change found in both the superior and inferior quadrants. To facilitate follow-up, I've charted the date visual field and OCT progression occurred, annotated when new glaucoma medications were started, and created a dual baseline on the visual field guided progression analysis. With a lot of value already demonstrated, and with this talk entitled OCT Pearls, my best advice would be use the macular cube scan with every OCT scan done. This will facilitate better glaucoma diagnosis and monitoring. From the introduction of the Stratus OCT, scanning the macula seemed the domain of the retina specialists. In the late 1990s, we knew glaucoma affected the macular structure. However, macular thickness proved inferior to optic nerve head retinal nerve fiber layer with the first generation OCTs. Nevertheless, exploratory research did continue. It was, however, only with the introduction of spectral domain OCT and the better resolution that it affords that macular scans have come to the forefront. With segmentation of macular layers now possible, we could now analyze and monitor the ganglion cell layer. This is an intuitive approach, as a significant portion of the retinal ganglion cell population resides in the macula. We now know that the Cirrus ganglion cell analysis is comparable to that of the best retinal nerve fiber layer and optic nerve head parameters. Moreover, this is even true for cases such as high myopes. Furthermore, we may even miss glaucoma damage if we only use optic disc scans and did not scan the macula. In this study, 11% of glaucoma patients did not have retinal nerve fiber layer changes but showed macular changes. In fact, the use of macular scans in clinical practice have gained urgency in the light of studies such as this, highlighting the problems with using retinal nerve fiber layer to monitor advanced glaucoma. In contrast, research actually suggests that ganglion cell inner plexiform layer thickness may be more useful in monitoring the advanced stages of glaucoma. Because I will be using many PanoMap examples in this talk, let me introduce or reintroduce you to this display. The PanoMap, in essence, merges the information found in the optic nerve head and ganglion cell analysis reports on a single eye basis. The striking feature is the wider field of analysis gained by the combination. Let me highlight key features. Arguably, the most useful feature is the wide field combined GCA and RNFL deviation map, which helps us better appreciate the distribution of damage. There's also the addition of an ETDRS macular thickness map. Now let's move to some examples of how the macular cube scan can facilitate glaucoma diagnosis. Let's consider if we should also diagnose right eye NTG in this patient with left eye NTG. Just looking at the right eye optic nerve head OCT, measurements do not look too bad. Average RNFL thickness is within normal limits. Rim area and the inferior RNFL quadrants are borderline. However, on closer inspection, the RNFL deviation map and clock hour graph may be pointing out glaucoma damage. Some may not give too much weight to it. But combine this with changes in the macular region, we get stronger evidence of damage at the so-called macular vulnerability zone of the optic nerve and the corresponding macular damage. This relation is perhaps better illustrated in the right eye PanoMap combined GCA and RNFL deviation map. Let's move on to progression. The Cirrus OCT and Forum Glaucoma Workplace has a macular progression analysis feature. average, total superior, and total inferior GCL and IPL thickness progression can be monitored. Do ensure that the signal strength is 7 or higher for each image. And note that a minimum of 5 tests are needed to determine likely progression. Another useful feature is the guided progression analysis change map, highlighting areas of possible macular progression compared to baseline in orange and areas of likely progression in red. This is a nice illustration from a recent publication by Hood. In the top series of 6 images, the region within the red rectangle appears to be progressing, and this change can be seen from the 3rd exam onward. In the bottom 2 images from another patient, the red arrows indicate change in the deviation maps between test 3 and 4. This is a patient of mine with bilateral normal tension glaucoma. The visual field defects are characteristic in that they are focal, deep, and close to fixation. To monitor her for progression well, she has baseline OCTs including a macular cube. 10-2 visual fields are also required. With a 10-2 visual field and a macular cube test done, we can also generate a structure function analysis. Here, the series structure function analysis shows good correspondence between the 10-2 visual field defect and the areas of ganglion cell thinning. For completeness, here are her panel maps. In her case, progression was detected not by the optic nerve head parameters seen on the top, but instead by the total inferior GCL IPL thickness strand and the change map. This series of her left eye deviation maps highlight the area of change found in the macular change map. In this next section, let me offer examples where the panel map feature may add value to your glaucoma evaluations. Frequently, we are referred patients for evaluation of cup disc asymmetry. My patient is such an example. One of the first tests ordered is an OCT. Hers is seen here. This shows a left superior quadrant outside normal limits. A few other parameters are borderline. Reviewing the left panel map combined GCA and RNFL deviation map, the thinner superior temporal disc rim, retinal nerve fiber layer, and ganglion cell layer come into focus. Visual field testing demonstrates a mild inferior arcuate defect with good structure-function correlation. Many of us screen so many glaucoma suspects, and I believe the panel map may help aggregate the OCT information and display it more intuitively. Here is another case, a lady with a family history of glaucoma here for her 2-yearly screening. Does anything strike you about the OCTs? The top of the screen shows the glaucoma workplace trending for her left optic nerve head. Now displayed is her macular cube trending. And these are her panel maps. I mentioned earlier that an additional feature the panel map had was the ETDRS grid of macular thickness. The left macular thickness grid stuck out for me because I rarely see pink sectors indicating increased thickness. As a result, I dilated her to have a look. And fortunately so, as I found a superior hemiretinal vein occlusion. To round up the talk, in using macular cube scans, we need to be aware of pitfalls in interpretation. This is because other conditions of the eye or macula may affect interpretation of the analysis. Like all OCTs, measurements of thickness and segmentation are affected by cataract, as demonstrated on the left. The signal strength is often the clue. Epiretinal membranes are common and can affect the macular cube scans as seen in the left eye here. A clue may be the increased macular thickness as seen on the left panel map. Sometimes you will see incidental macular holes or lamellar holes. Macular pathology, such as scars, will also cause segmentation errors. Segmentation errors may also be caused by scans with poor signal strength, and they may flag up as progression. Here are 3 scans taken at different time points. The former and latter are before and after the segmentation error. The middle scan, left eye here, shows the unexpected segmentation error. Finally, structures pushing from the pigment epithelial layer, such as a PED, may thin layers above, as seen in the left eye. In summary, OCT is established in helping diagnose and monitor progression in glaucoma management. Improvements in OCT resolution allow good segmentation of the macular region layers now. As a result, ganglion cell analysis is now another modality of diagnosing and monitoring glaucoma. It may even be better than RNFL for advanced glaucoma. Finally, we now have new visualizing tools such as the panel map to help OCT monitoring of the posterior pole. Thank you for your attention.
Hello everyone, thank you so much for the invitation to this interesting Asia Pacific Glaucoma Society webinar, and in the next minutes I'll be talking about perimetry advancement in glaucoma management. These are my financial disclosures, and this is the outline of my presentation today. We will cover 3 major points. The first one will be time in perimetry evaluation and how the tests have become shorter. Second, locations and new points to better assess macular damage. And 3, new things to better assess progression. All right, we will start with time. We know that time is important. In fact, longer tests are not only cumbersome for the patient, but may obtain less reliable results. For this reason, in the last years, we've been seeing changes in the duration of the test, having every time shorter strategies. And we've been going from the CETA standard to the CETA fast, and now to the even shorter CETA faster. And why the CETA faster is actually faster? Because it does include 7 different modifications to the CETA fast. It starts in 4 points with a level of stimulus with a threshold that's already corrected by age to make it shorter. It only requires 1 single staircase test reversal instead of 2. It uses CETA fast normal distribution as a model and compared to full threshold. It doesn't do retest of blind points or false negative Koch trials anymore. It only uses Humphrey gaze tracker as fixation, and there is an elimination of the extra delay between stimulus. And after doing this, SITA faster is 50% faster than SITA standard and 30% faster than SITA fast. When we compare the three algorithms, there are almost no differences between SITA fast and faster in terms of global indices like MD or VFI, and very small differences between SITA standard and faster that are actually almost no clinically significant. Therefore, in this very interesting paper from Anders Hehil, they conclude that it would be really interesting to use these shorter strategies, especially if this allows us to increase the frequency of the test that we know is crucial to better assess the rate of progression. And here I have several examples for you so you can see the differences of test duration. This is one patient with a mild glaucoma, and we've done a standard 24-2, fast 24-2, and faster 24-2. You can see that we are able to reduce time from 5 minutes up to less than 2 minutes. In this other patient with advanced glaucoma, the reduction is less, and we go from 6 minutes up to around 3 minutes. And now we will move on to the second point of our presentation, which is this idea of adding new test locations to better represent the macular area. We know now that the macular damage is much more frequent than we thought in glaucoma and that it can appear early in the disease. However, with the standard strategy of 24-2, we are not able to adequately sample the macular region because only 4 tests fall within the central 8 degrees. And this is not sufficient to represent completely the amount of retinal ganglion cells that are already damaged in this area. And for this reason, there's an increasing tendency of using also 10-2 to better characterize central damage. There's several literature published compared 10-2 to 24-2 in patients with early to moderate glaucoma, and they found that up to 50% of patients had already changes in the 10-2. And moreover, up to 16% of patients that had a completely normal 24-2, they were actually found to be abnormal in the 10-2 test. Alright, so should we then do 24-2 and 10-2 to all our glaucoma patients? Well, this is not completely clear yet. First, because doing both tests really increases time. You can see an example in the top of the slide. 24-2, it took almost 3 minutes. We then perform a 10-2 that was 6 more minutes. And we know now how important time is. And second, because there is no strong evidence supporting this, and actually a recent prospective study did not find higher diagnostic performance of 10-2 detecting those central visual field changes. In this same article, they suggest that it may be more prudent to reserve this extra 10-2 testing for following up selected patients that are at a higher risk of central visual field progression. And then this idea of the SITA Faster 24-2C appeared in an attempt to combine the possibility of including these central points, or at least the most important central points, but without making the test a lot longer. So SITA Faster 24-2C combines all the 24-2 points plus 10 selected 10-2 points, as you can see here in the figure. And in terms of time, this strategy only adds 30 seconds to the SITA Faster. And it's actually, even including these points, 20% faster than the 24-2 SITA Fast. And how about the results of 24-2C compared to 24-2 and 10-2? Well, in fact, they are very comparable, and the 24-2 found very similar global indices to 24-2, but it really was able to identify more central defects, which is logical by the nature of having a greater number of points in that area. When compared to the 10-2, there was substantial agreement identifying these central points. Therefore, it's been suggested that combining both tests in this idea of 24-2C would be possible and would be even a good idea to not having to do both tests together. And it has been suggested that 24-2C could be very useful for screening to never miss this central damage that is more frequent than we think. I have one example for you. This is a 57-year-old female with a focal temporal inferior rim notch and a normal pressure of 14. You can see here this cupped appearance of the disc with a characteristic reduction of the superior and inferior retinal nerve fiber layer of the nerve, and these changes in the macular area. However, in a 24-2 standard perimetry, we did not find changes, very inspecific, and nothing on the central area. We then perform a 24-2C in this patient. Again, you see here the cupping and this superior and inferior retinal nerve fiber layer thickness reduction, and how, when we further study the central area, we now see this macular damage that's very characteristic of normal tension glaucoma. Therefore, 24-2 can be used for screening. We've seen that 24-2C is very good detecting central damage. Then, does this mean that I will never need to do 10-2 in these patients anymore? Well, this is not true, because 10-2 has a better structure-function correlation compared to 24-2C. This is obvious because there is a greater test density and resolution of the 10-2 grid in the central area compared to the 24-2C. This means that in some situations, 10-2 will be more able to detect central clusters. And although 24-2C will be very good to screen, to detect damage, 10-2 will still be needed to confirm certain defects or to fully characterize the central defects of these patients. And when it is advised to do this 10-2 to further characterize the central defect, when any of the 4 central points of the 24-2 are more negative than minus 15 decibels, in those patients that are at a higher risk of central visual field defect deterioration, like those patients with deep focal defects, normal tension glaucoma, or myopic patients, or when we find a significant change in the central points of the 24-2C. And I'm showing here one case. This is a 55-year-old female with cupped disc, normal pressure, this very focal inferior rim notch, and we can see here this central point in the 24-2 that is very much affected. However, at a glance, it looks like there's not a lot of damage. In this case, it is important to do a 10-2 that will characterize better this paracentral defect. And we will see that actually it's not only a little bit of damage, but a bigger central damage very close to fixation. And this leads us to the third point of our presentation, that it is assessing progression. We've seen how interesting 24-2C is to both study periphery and detect central damage in early glaucoma. But will this affect my GPA evaluation? How will I see these central defects in the event analysis? Well, good news are that both 24-2 CETA-FASTER and 24-2C CETA-FASTER are included in the GPA evaluation. So we will still have VFA and we will have a normal GPA curve, and moreover, we will have a normal periphery event analysis with the triangles as GPA usually does. If we have as a baseline 24-2C and enough test, we will also have event analysis for the central points. And I have one example for you to show you this. This is one patient that has been followed for some time now. The first two tests are 24-2 CETA, and from this point, the tests are 24-2C. So if we do GPA, what we see is this trend analysis with a rate of progression that is minus 0.5% per year in terms of VFI. And we have the event analysis here with the triangles as usual. Because the two baseline are 24-2, we get the usual periphery analysis, just as normal, even if we have this extra information here that we can see that there are some central points being already affected in this patient. If we have a baseline that includes 24-2, see, this is the same patient, but we start GPA at the point of the first 24-2, if we have these two as baseline, we then are able to have the event analysis for the periphery, but also for these extra central points. So for progression, if we use 24-2C, we will get the trend analysis of the global index for the periphery, the event analysis of the periphery, and then event analysis of these extra points. So we will have some idea of central progression. Okay, in summary, we've seen that time is important and that 24-2 CETA-FASTER is able to obtain good results in less time, that 24-2C has additional central test locations that are very useful to screen macular damage, adding not a lot of extra time, but that there are still some situations in which 10-2 is more useful to characterize central damage, especially in cases that are a higher risk of central progression, and that both 24-2 FASTER and 24-2C can be integrated in the GPA evaluation in a way that we can have global progression, trend of progression, and then event analysis both for periphery and for these central points. And this is all for today. Thank you so much for your attention, and I'm all ready for questions.
I would like to commend our three speakers for giving excellent and very clinically relevant talks as far as us managing our present-day glaucoma patients. I would like to begin this question and answer session by first thanking my very good friend Manchima, Leonard, and Marta for reminding me how old I am. You know, I probably am the oldest person in this session. And believe me when I say that I have seen it from the very beginning. My career as a glaucoma specialist started when we had manual perimetry, when we did not even have OCT or, you know, the developments of automated perimetry. So I speak from experience when I say that I am so glad to hear about these new developments in technology that make our life and ultimately our decision-making in handling glaucoma patients much, much easier. All right, so thank you. So now we have questions that are coming from our audience. And if you don't mind, I will throw these questions to you, and maybe anybody who would like to answer can respond. All right. One question is for Professor Manchima. The comment says, I do agree that EMR and reviewing software like Forum may improve the care of our patients and make clinical decision-making easier. With regards to Forum, don't you think that the software is not scalable and does not allow too much flexibility? It says that it only provides global trend analysis and no point-wise trend analysis. Also, it excludes the trend analysis field flagged as low reliability, even though many studies have shown that, fixation losses are not that important. So the audience feels that I find Forum useful, but I think it does not allow extracting all useful information yet.
All right. Thank you for the questions. I would say, I'm so glad you raised this up, because in terms of glaucoma doctor, I don't think there's anything can replace what you are doing. It's just to help and support you in some point. So the Forum, definitely, they're gonna gather everything all together, but it's not everything, definitely. And you are the one who have to tell, the machine that this one is not reliable. You have to take this out from the analysis of them. You have to probably delete this one. This one probably, the subjective is probably like unreliable. You have to like cut something out and make it like a good own shape by yourself. So yeah, I don't think there's anything that is replacing what we are doing as a clinician, but these can help us to gather everything all together. And definitely don't forget that all together is reliable with unreliable and trustable and probably like vast. So you have to like pick them out and also choose by yourself and gathering them around and make it like by your own to make it like an own shape, and then leads you to whatever you need, because the machine is just to help you and support you for the time to see everything like at once and then make decision at the point. So yeah, you still be the one that to take care of everything anyway.
So Manchima, this technology allows us to easily correlate all the findings in a patient. But am I right in saying that it does not invalidate the old manual technique wherein you still gather your printouts, you still analyze your disc photos using your eyes, correct?
Definitely, yeah. That's absolutely.
I mean, how we wish everybody would have access to systems like the Forum, but the truth is, not all clinics or institutions, particularly in this part of the world, might have access to such fancy and sophisticated systems. All right. Leonard, you were saying that these machines use or need a minimum of 5 tests for them to be able to gauge progression, correct?
Yeah, that's for the linear regression analysis.
Correct.
Yeah.
What is the interval that usually you would recommend between those 5 tests?
Well, essentially, the more data you have, it's always better. But there's always this balance you have to make for your patients between the number of times they have to come and how frequently they come, and then the costs incurred by doing the test. So in general, for establishing quickly a baseline for OCT, it's best if you get the first 2 scans done as close as possible together. I think an interval of 3 to 4 months is quite a reasonable separation for a baseline scan. Then the subsequent scans can be tailored to other clinical factors that you might want to assess, like what you assess the risk of progression for this patient is based on their intraocular pressure control and other factors. So I think there's no one best answer for this. You know, in a very stable patient, you might do it even as far as a year apart away. In someone you think that could be at higher risk of progression, where you want to pick it up faster, then you would do it more frequently.
And if I remember right, Leonard, you were recommending that when you do an OCT of the optic nerve, you also do a macular cube, correct?
Correct, yes. So when I'm doing an optic nerve head scan, I also do the macular scan at the same time. The increase in time for the patient is very minimal, maybe an extra minute or two, but yet the amount of information that you gain is phenomenal in terms of being able to monitor this patient better for progression in the future.
In a situation wherein you will have a normal optic nerves macular scan and a questionable or an abnormal macular scan, will that be enough to push you into, committing to a diagnosis already? Or is this just going to be a stepping stone to what you're going to do next?
I still like to do visual fields. So if I had a normal optic nerve head scan, but an abnormal macular scan, I would probably order a 10-2. I think Dr. Pazos had a very nice example
Correct.
There, and that's supportive of the stand that the 10-2 has a place in early glaucoma as well.
All right. Martha, I asked this question because here, at least in the Philippines, the general practice is that the 10-2 is only ordered when the general visual field is already tunnel or very constricted.
Advanced glaucoma.
Correct. Now you are telling us that even on a routine baseline scan, wherein you do not expect major visual field defects, you would suggest looking at the central visual field. Correct?
Yes, there are several studies showing that macular damage, like early central affection, is much more frequent than we think in early disease. Having said that, there are several situations in this is even more frequent, So there's no evidence to support to do 24-2 and 10-2 in every single patient. And as you were saying, not everyone has access to everything, right? So the easy way to solve this is to use 24-2C, because you at least get some central information at the beginning, so you don't miss this. But there are still several things that can flag your head that you may, in that particular patient, do 24-2 and 10-2, even in an early glaucoma. For example, in normal tension glaucoma, because central damage can appear early in the disease. For example, when you have a 24-2 that already has a central little point, but very deep, very
Correct.
Black.
We see that a lot.
With that, because you see that a lot. So you should then perform a 10-2 to better characterize this defect. And then in other situations, like when you have a, very deep and very focal notching of the rim, especially in myo patients, because this has also been shown to be more related with paracentral damage that can be non-seen in a 24-2, because those 4 points, do not represent well all the central damage. So in that situations, you should do a 10-2. Having said that, if you have the 24-2C, then you can do this more routinely in certain situations, not to miss the central points, but it's not mandatory to have it.
For those of us who are not too familiar with the 24-2C, that is a software upgrade for those who currently have a relatively up-to-date model.
Yes, you need to have HFA 3, like the last model, to have that. And it's a software change in the CETA-FASTER, in which you get like the normal 54 points of the 24-2 plus 10 selected central points. And the thing of this is that you somehow have central information
Correct.
without adding a lot of extra time. But as I said in my presentation, this does not completely substitute a 10-2. But it's a way of having something quicker that gives you information. And you can do this very easier, you know, than doing both tests together.
All right. Now, another question from a delegate. Do you usually dilate pupils for the CT Faster program?
We don't usually dilate pupils. We just do it without dilation in all our patients, just standardly. No, we don't dilate.
Would you say that a minimum of 3 millimeters as far as pupillary opening is already adequate?
Exactly. I mean, in certain patients that are under pilocarpine or that really have a really bad pupil, then we will dilate, but we don't dilate systematically.
Another question. Regarding segmentation errors, can the current artificial intelligence software used in glaucoma management detect and automatically correct segmentation errors?
Well, let me answer that. So
right.
I would say that the machine currently officially doesn't use artificial intelligence, but it's not able to really detect the segmentation errors, and these segmentation errors can occur, of course, the most common reason due to signal strength problems. And I guess what you would have to do is to train your technician to be able to realize that it has occurred, or to train your technician to always try to get good scans with signal strength 7 or better. If that's still not possible despite his best attempts, then I would recommend that you try to do your OCT scans dilated. And there are many papers, including my own, that have shown that a pupil dilation improves substantially the signal strength from Cirrus OCT scans. And that also improves the segmentation, as you would expect. Yeah, so that's the solution. Unlike visual fields, you dilate and you get better scans. Yes.
Correct. Correct.
May I add something? Can I add something to what Leonard said? Because I also find to have a lot of segmentation errors when, you know, there are epiretinal membranes or things happening in the macular zone. So I really encourage, you know, my fellows and my residents to always look at the deviation maps. And I like so much Leonard example that I have to say that it was, you know, you always have to take a look to that, because you will always get, you know, a color code representation. You will always get red sectors, yellow sectors, no matter what you do. And you really need to interpret as a doctor what you get. So even if the signal strength is good, you need to check the segmentation to make sure there are no errors there. You may get that even in a retinal nerve fiber layer exam because of, for example, a posterior vitreous detachment, and you can get a completely, you know, zero thickness in that area. And you will get a normal red thing in the color code database comparison. So you need to be trained to only take into account those images that have good segmentation. And, you know, unfortunately, the machine doesn't do that for us yet.
There's real intelligence at your disposal, so not to worry.
not artificial.
It's just your intelligence, not the artificial.
Yeah, this is actually the same that, you know, the first questions that we talk. I think we all agree that the machine is just to support us at some point. And if you see something wrong, please get back to the original one first to see, is that one reliable or not? Because sometimes you see the PVD, like the dense one, and then you lost that signal at that segment, and something seems to be, like, you know, went wrong, but actually there's nothing else at all. So yeah, we actually still, you know, use our, you know, like potential to take care of this anyway.
These are very great reminders to the young people in the audience, particularly those who are still students. They might have a tendency to just completely rely on what the machine tells them, and without having to correlate and analyze and weed out the extraneous, you know, there is always that tendency that you will have to always fight. Now, the next question is probably for Marta. early glaucoma detection in a high myope. Which one is more appropriate or better, 24-2 or 10-2?
Well, myopes are always a problem for everything. They are a problem, high myopes especially,
Correct.
for OCT. I mean, everything is more difficult with them because of, you'll never know which, if the damage you're getting is from the, myopia itself or from glaucoma.
Correct.
So, in my experience, there's a huge difference between this high myope that has already macular problems because of the retina problem from that high myope that has a macula that's structurally not that affected by, let's say, atrophy of the choroid or something like this. I normally do 24-2, and now that I have 24-2C, I use it a lot of times because that somehow makes me feel safer in terms of the macula. But for myopes, there's nothing 100% effective. And in those myopes that you have already central damage, you will get confused all the time and you'll never know. So in those, progression is the key, progression with themselves. And some of them, even with this, you'll have also difficulties because you'll never know if the atrophy is progressing or the glaucoma is progressing. I sometimes use even retinography in those patients, like in the old days, to compare if those focal areas or if those changes in the atrophy of the retina are changing. So the answer is difficult, but just do as much as you can and try to compare the patient with time to make sure it's not changing.
One question here is that, can 24-2C replace SWAP strategy? Do we need SWAP anymore?
Okay, I mean, they look different things. SWAP looks, it was used like some time ago for early glaucoma because there was this idea that this blue-yellow stimulus could detect or could find some changes earlier on time. There's now some evidence for the last years showing that SWAP is not very useful because of the variability. It's really variable even among the same individuals. So with time, we are not using it a lot now because of this, because there's a huge variability. So you never know. But 24-2C, because it's in the FASTER protocol, is fast. That was something also good for the SWAP because they were faster than 24-2 standard. So I think it's a good idea to do it, to scan in screening. And then also having these extra central points to catch those early glaucomas that affect the fixation. But we rarely do SWAP now.
Leonard, in a situation wherein your RNFL are normal, but the GCL complex shows significant thinning, how do you make of that situation?
Well, there could be a couple of reasons for that. Probably the two most common would be one, that due to there being a significant cataract being in that eye, I believe it could affect the macular scan more than the optic nerve head scan. So that's one possible reason you have to consider that the signal strength affected by the cataract. The second is back to that problem of the high myope. So as you can imagine from being a high myope where you have longer axial length and overall thinner retina, you also end up with a thinner macular area, and that you would probably see a global reduction in the ganglion cell in the plexiform layer at the macula. And that would be an indication that this is the problem that's causing the finding. So you have to consider signal strength due to cataract and also myopia in such cases. Of course, glaucoma is always possible as well. Yes.
So again, the reminder here is we have to look at the entirety of the
Yeah.
clinical findings and the findings that we get from all these sophisticated tests. One alone is not sufficient enough for us to, rely on, correct? I think for our students, that is a very, very important lesson for them to always remember.
One thing that I would like to add to this question is that it's also interesting, and that would, be a long conversation in a different webinar. But one thing that is very interesting is to look at the shape of the defect in terms of the ganglion cell layer. To answer that reason, you could find a completely normal retinal nerve fiber layer, and for example, a vertical defect on the ganglion cell layer, and that would suggest that you're having maybe a stroke, because you're evaluating the whole visual pathway, not only glaucoma. And that sometimes happens. It's red, that means you need to also take a look at the shape of the defect. The way glaucoma works is with focal defects. It has been described as a snail shell appearance at the beginning. So if you see that in the macula and a normal, let's say, green sectors in the retinal nerve fiber layer, that could be glaucoma, because sometimes when you look further in that green area, if you go to the deviation map, the retinal nerve fiber layer is not that normal. It's just that it's very focal. Because if not, if you see a different shape, for example, this vertical, then it could be something in a different area, even a primary disease of the ganglion cells, okay? Also, if you see a diffuse shape, then that would go more for these examples Leonard was talking about, high myopes, low signal strength. So we need to look further, not only the colors, we need to look at the deviation map, look at the segmentation, and then also look at all the clinical information. Just like Dr. Manshima was saying, we need to also in this patient take a look at the visual field, because maybe we see a hemianopsis, and then that's not glaucoma, right? So we need to use all the information we have in our hands to make the right decision.
As we teach all our students in glaucoma, the essence of diagnosis relies on very good structure and function correlation. One without the other might not be glaucoma, all right? So
Exactly.
Again, with all this help from the technology that you so eloquently discussed with us tonight, I would like to think that we would be better practitioners of the specialty, because now we know that we have not only ourselves to rely on, but we now have very good technology that can help us make our patients' life much, much better. So is there any other comment or last message that any of you would like to impart to our audience?
Can I add something?
Sure, sure.
I just would like to express that if you want to compare the result of your patient, which is sometimes from many resources, because patient traveling around this machine to that machine, you probably have the paper head to head compared to each other. That's probably comparable, but you have to make sure that it's in the same protocol, like 24-2, 24-2C, or 10-2. Don't just compare it with without taking care or concern of this, or else you would probably be misled by this kind of things. Yeah. Thank you.
All right, very good reminder. You do not compare apples with oranges, correct? Correct. So at this point, I would like to end this webinar, first of all, by thanking the three speakers that we had tonight. Thank you for such an enlightening hour and a half as far as glaucoma diagnosis is concerned. So the Asia Pacific Glaucoma Society would like to express its thanks to Manshima, to Martha, and to Leonard, and of course to our industry partner tonight, Zeiss Meditech, for making this webinar possible. I would like to invite all the attendees to our next APGS webinar in October. You will get your information regarding this forthcoming webinar very, very soon through the emails and through the different notifications that we have. I'd also, before we end, would like to advance an invitation to the 2021 APGS Congress that is going to be hosted by Malaysia. So again, everybody, thank you. We are very grateful for all the time that you spent with us, and I hope everybody keeps safe. Good night, everybody.
Good night.
Good night, and
night.
thank you.
Thank you. Thank you very much.
Bye-bye.
Bye-bye.
Bye.